First speaker this morning is Dr. David Hilger, one of our radiologists here, and he will be speaking to us about lung cancer screening and AI's role in early detection.
Morning, it's an honor and pleasure to be with you first thing this morning for the first talk. And thank you, Brandon, for asking me. So we're going to be covering 5 areas this morning in 30 minutes. We're going to talk about the purpose of screening, the benefits and risks of lung cancer screening, a little bit about effectiveness. I'm going to give a little short update on the Lung Rats 2022 and show a few case examples. And then we'll talk about current and possible future role of AI. So we'll start out with we have 30 minutes. We'll start out with a 30,000 foot viewpoint, and then we'll kind of hone in from there. So this is a few years back, but the relative rates have not changed. The numbers have changed a little bit, but still top 10 cancers: female breast, followed by male prostate. Number 3 is lung and bronchus, followed by the others that you see on the list there. However, lung and bronchus cancer has the highest death rate and the highest number of deaths of all cancers, followed by female breast and then male prostate. So obviously it is a important cancer to find early and to move forward in our ability to treat and find. Males versus females, not surprising. Lung bronchus is twice that of prostate. Prostate is next, followed by colon and rectum. In females, lung and bronchus also the highest, followed by breast, colon and rectum, and then pancreas is number 4, and then for both sexes, and then following down the list. So these are probably not surprising statistics to all of you, the relative risk of those different cancers. Overall survival of lung cancer in 2024, 28% 5-year survival. That is up a bit, a modest amount from previous years. And why is that so low? It's because the symptoms of lung cancer typically do not appear until the disease is advanced. And most of the patients are diagnosed still with more advanced disease. On the other hand, and this is statistics a little bit back from 2018, may have improved a little bit from there, but approximately 20% of lung cancers are detected early. But if found early, lung cancer has a much better 5-year survival, over 65%. So stressing the importance of early detection. So we're going to talk about what a screening test is. Something I've been very interested in my career, 40-year career in radiology. I've been one of my other areas of expertise I work a lot in is breast cancer detection. I feel that as a radiologist, if I can find something early, it just makes such a bigger impact on things. And then I got interested in lung cancer screening when I came here to Omaha in 2008. So the purpose of a screening test is that a disease is easier to treat or cure if detected early. The value of the test is determined by, and there's other values, but the overall value by the powers to be is determined by decreased mortality. Examples are mammography, low-dose CT for lung cancer, colonoscopy, PSA measurements for prostate. In radiology, we have all these acronyms. We have BI-RADS for breast, we have lung RADS, LRADS, lung RADS for lung, we have PI-RADS for prostate. Now we're getting ORADS, we have TRADS we have all kinds of RADS. It's like this big pool of acronyms. We do have computer-aided diagnosis, which is AI. It's a form of AI. We use that for breast cancer detection, which is actually the most advanced form of what we have now. It's getting better and better. But we also use it for lung cancer. The others not really using it, but I think it's going to spread into other screening modalities. I think the other screening modalities are kind of ripe for that development of computer-aided diagnosis. So I like to give, I guess I really like this quote from Thomas Adams. He was the third son of President John and Abigail Adams. So this is way back. Prevention is so much better than healing because it saves the labor of being sick. So why hasn't lung cancer screening been routine? Until recently, and that's recently, I'm maybe saying 10 years or so, there hasn't been an effective screening test. Chest x-rays have no benefit for early detection. By the time we see it on a chest x-ray, it's advanced. So we're going to talk about the evidence for low dose CT screening. And there is some good evidence. We're going to go back to the ILCAP study, which this institution participated in. I was involved in that, and we were very involved in that. It was handicapped by the lack of a control group. So its evidence wasn't really very well accepted because you need a control group to make it a really high value study. The Nelson screening trial in Europe was a pretty good randomized controlled study. Over 20,000 people screened. They had a 26% mortality reduction, published in 2020, which was pretty good. And then the biggest study is the National Lung Cancer Screening Trial, NLST. Final data came out in 2011. It was a large clinical trial, over 50,000 patients at risk for lung cancer were screened, ages 55 to 74. They were current or former smokers. It was randomized to annual low-dose CT or chest x-ray. So it was a randomized study. And what it defined, it found those who had a low-dose CT had a 20% overall mortality reduction for the whole group. But how does that compare to other screening studies? The other statistic to look at is that you need to screen 320 people to prevent one lung cancer death. Now, how's this compared to breast cancer? Breast cancer is 1,339 or over 1,000 patients for avoiding one breast cancer death. So this is a mortality reduction. It's not cancer detection rate. And that's, I mentioned earlier, screening studies are based on mortality reduction. So there's other benefits of screening studies besides that, obviously. They're easier to treat. So in 2021, the U.S. Preventative Services Task Force published some new guidelines, which is the ones we follow now. Lung cancer, 50 to 80 years old, currently smoke or have quit within the past 15 years, and have at least a 20-pack year smoking history. So previously it was what you can see there. In screening studies, we have something called a pretest probability. So somebody enters a study because they're a smoker, and that's a pretest. They have a higher pretest probability. That's one way of looking at it, but the real way we look at it is something called the likelihood ratio. The likelihood ratio includes a pre and post-test probability. That is, you have a population you're screening, and they have a higher pretest probability. How much does it increase the probability of disease after they have the screening study? And so that's the likelihood ratio. And so that's really what we look at to evaluate a screening study for a large population. And that's what the USPSTF looks at. So what are the risks of screening? Obviously, there's a radiation risk. There's false positives, finding a nodule that is not cancer, causes anxiety. Most nodules are seen on CT are not cancer. Most of them have nodules, especially if you live in Nebraska. We have a high rate of histoplasmosis as a nodule. And then it may require additional testing and procedures, and they themselves have some complication rates. So here's the relative risk of radiation. I like to put things in perspective, especially patients that come in and ask about their mammograms and how much radiation they're getting, or and so just flying 10 hours somewhere gives you a higher radiation risk. You're higher up in the atmosphere. You have more radiation from the sun. A chest X-ray, next a mammogram. These are, the measurement is millisieverts. In case you're wondering what the MSV is, that's the radiation that we talk about. That's the unit of radiation we talk about nowadays. So then average background radiation is the second to the right. So just living here in the United States, depending on where you live, of course, if there's a range there. If you're in Colorado, living in the mountains, you have higher risk than if you're in the Great Plains. So it's 3 to 5 millisieverts. So a low dose CT is about 1.4 millisieverts. So that's kind of relative risk. So it's still pretty low radiation. A regular diagnostic CT scan, just one CAT scan, is 7 millisieverts, and depends on how big you are and what kind of scan is being done. So it can vary. So this is some national data now. Where are we at? This is up 18 in 2022, and it's probably up from there. 18% of eligible patients nationally were screened. So that's still low, but that's up from what it was from a previous published number, I think was 9 or 10%. So it is up, some modest increase, and it's state variable. Some states have really promoted it. Rhode Island, 28.6%, lowest in Wyoming. I think we're somewhere in between Nebraska. And the 5-year survival rates have increased to 28%. That's a modest increase from previous data, and that's 2024 data. Okay, we're going to talk about artificial intelligence a little bit. I think we're running on time here. I turned on 60 Minutes about sometime in the last year, and Professor Hinton, who received the Nobel Prize, was on, and I just happened to turn it on. He said this: people should stop training as radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. So I thought, I don't think he's right. I don't think that's right. That was November 2016. By the way, I think AI is a misnomer. It's if you talk to people, and my niece is in graduated from the Rakes program, it's called deep learning or machine learning. That is truly what it is. We're teaching machines to do things. It's not a person. It's not a human being. So anyway, I just kind of laughed at this, but it's been well publicized what he said. The truth is, we haven't got rid of radiologists. There's a shortage of radiologists, just like in all areas of medicine, and the shortage is predicted to persist until 2055, with increasing volumes of imaging procedures. There is a rapid increase in cross-sectional imaging. The Mayo Clinic called it the radiologist gerbil wheel. At that time, they said radiologists were looking at one cross-sectional image every 3 to 4 seconds. And that's gone up. I mean, we're seeing increasing volumes. So I'm saying, hey, bring on AI. We could use all the help we could get. Just apply it correctly to help us. And we use a form of AI or deep learning, which is the Dynacat software. And it is helpful. It does help me. It helps me read things faster and better. I can't make a little circle around that nodule near as well as the computer can in measuring it. So my hands don't, what it's like. It's just not, they do it, it does it much faster. He came back in later and kind of changed his tone a bit. The role of radiologists will evolve from doing perceptual things that could probably be done by a highly trained pigeon to doing far more cognitive things. Okay, and that's an AI generated pigeon. I think what he's saying is that I think what he meant to say is that the AI is the pigeon. we need to train the pigeon. And we're doing work that maybe we need to do more thought processing work. What we do. We'll talk about that a little bit more. I really like this graph. I think this is so important in what we're dealing with in our expanding knowledge and technology, which we're all facing, whatever we're doing, is that our human adaptability is lagging behind the pace of technology change. And we're all facing that in so many areas. And so that's, if we can use AI to help us bridge that gap, I think that's will be an important role of AI, in my opinion. So help us learn how to do things more efficient and better. So let's talk about lung cancer screening a bit. Three big categories. These aren't the only categories. A negative screen, which is we call lung RADS 1 or 2, 1 for negative, 2 for benign. Positive screen indeterminate for cancer is a lung RADS 3. And we'll typically follow up these patients, do a short-term follow-up, 3 to 6 months, whatever. A positive screen suspicious for cancer is lung RADS 4, requires further testing or biopsy. So you probably is aware of these, anybody that's involved in this. And we have similar things for breast cancer and prostate. We use the same categories, so that it's easy for the clinician or the other person that's reading the on the other side to know. Everybody's used to, okay, a 3 is follow-up, a 4 is abnormal, take action. So, but here's how complicated these are the current lung RADs. It's really a complicated, this is only one page of 3 that I'm going to show you. And so it is a highly cognitive function. It's not a pigeon. The computer helps us. So the changes in lung RADS 22 from previous, we now use the term juxtapleural nodule. A lot of people still use, and I think it's still okay to use periphyseal nodule. The fissure is a part of the pleura, but that's their change was juxtapleura. I'm not used to changing my terminology to that yet, but airway nodule include instead of an endobronchial nodule is one change on that. And then the real big change was pulmonary cyst. Here's the lung RADS 3 category, which is probably a 9. So a pulmonary cyst can be a short-term follow-up, or it can be a suspicious finding that needs to have action taken. And I'm not putting that up here for you to look at all the details, but there are some defined criteria of cysts, and that was a really big new addition to the lung RADS 22. You can pull that up on the internet if you like to. It's easy to find. So I think we're all kind of getting used to that. That whenever there's a lung RADS or a BI-RADS change, it takes a while for all the radiologists to adopt those. So what are the nodule categories? We have solid nodules, different types of descriptors, non-solid, which are usually followed. Part solid is a combination of the two, and then cystic or atypical cystic nodules. So just some examples here. This was from lung RADS 1.0, which is now changed to lung RADS 22. This is an example of a fissure nodule. I don't have a pointer, but I think you can see the different types of fissure nodule. The typical fissure nodule or juxtapleural nodule, atypical, which is likely benign, and then the ones that are eccentric from the fissure or spiculated, those would not be fissure nodules or juxtapleural nodules. So the little arrow up there shows you a typical fissure nodule. A lot of people just ignore those or describe them as benign. So here's one that's not a fissure nodule. This is eccentric from the fissure. It's irregular in shape. And the PET scan has a little box around it. And then if you look at the image to the left of the one that has the box around the nodule, you see there's a mediastinal adenopathy there on the PET scan. So this was already involving the mediastinum. Here's a couple examples of solid nodules. The one on your left was a cancer. It had regular margins, had cavitation or pseudocavitation, sometimes it's called. The one on the right could be benign or malignant, but it's large enough that it needs to be evaluated with a PET scan or a biopsy, perhaps by bronchoscopy, navigation, if it's a new nodule and it wasn't there before. So here's an example of the type of nodule which I've seen the AI miss, the computer-aided diagnosis. And so when I look at these screeners, take special care to look along the mediastinum because I've seen some fairly aggressive lung cancers missed. Now, the AI's the deep learning is getting better and better all the time. The more data you put into it, the more experience it has, the better it gets. And so I don't know, this probably would not be missed now, but in my previous experience, sometimes these are the ones that were missed. So I look really carefully along the mediastinal margins, and you can see that what's lighting up and then the nodule that corresponds to that on the PET scan. This one also had another area of activity. So this is the kind of nodule that could be missed. This is an example of a non-solid nodule. You see it's kind of hazy, and we follow these typically until they get to a certain size or they start changing their character. Sometimes they can be biopsied. This one could be percutaneous biopsied or because it's peripheral. Here's an example of a non-solid on the left and a part-solid nodule on the right. You can see the difference. The part-solid nodule has an irregular density there. And we're particularly concerned if a non-solid nodule turns into a growing solid component. Here's two examples of part-solid nodules, and you can see the hazy part of the nodule versus the solid part of the nodule, hopefully, just to point it out. So we determine our approach on these. We measure the solid component, and that's the area that we determine how we're going to suggest if they get a PET scan or whatever, if it's on basis of the solid component. Here's a couple of additional part-solid nodules, or cystic nodules, actually. And then the nodule on the left, you can see those little lucencies. So we call that pseudocavitation. That's one of the signs of malignancy that occurs. Is little cystic areas. So this would be in a BI-RADS or a lung-RADS 4 category. It would need more evaluation. The cyst on the right, we'd be evaluating that cyst according to the solid component on the wall. You can see the little solid component coming out there, especially if that's growing. So we would measure and base our evaluation on the change of that solid thickening or component, and that's just kind of how we handle complex cystic nodules. Okay, coming to an end here, going to wrap up. I think we're in pretty good time. So I'm just going to give my educated opinion on AI or deep learning. AI, I think, will serve an important role, including a second reader for radiologists. It's already implemented in Australia as a second reader for mammography in the whole country. So mammography seems to be ahead of other screening modalities. I think we're going to see more precision medicine. We're going to combine genetics plus the clinical risk factors to have a pretest probability. My opinion, I think that's going to be more incorporated, and maybe AI can help us with that. Some of my colleagues, of course, as they biopsy nodules, you also get data on the epigenetics of the nodule. And so that predicts, a little bit that's very important for the prognosis. I think diagnostic radiologists could evolve into more of a diagnostician, integrating multiple data for management advice for the clinicians. It could happen. But I do think, I'm fairly certain that AI will be increasingly used as a diagnostic assistant to help us in what we do. So, and any questions for the educated pigeon?
For our next speaker, I'd like to welcome Dr. Sumit Mukherjee. He is a pulmonologist with Methodist Physicians Clinic, and he will be speaking to us this morning about the differential diagnosis in lung nodules.
Thanks, everyone. I have about 80 slides to get through in 30 minutes. And I will talk about some things that Dr. Hilger just talked about and give you some examples of some radiology things. So we'll go ahead and get started. I'll kind of cruise through some of this and we'll be moving pretty quickly here. I am a consultant with Intuitive Surgical. I'm not going to be talking about anything relative to these conflicts. So we're going to talk about the thoracic anatomy and radiology. The anatomy is actually very important when it comes to differentiating these pulmonary nodules because it tells you a little bit about what the differential might be. So we're going to talk a little, just briefly about that, understand the differential diagnosis of these nodules, and then discuss just briefly some management options as well. So first of all, as I mentioned, going through the radiology review, understanding kind of what the functional anatomic unit of the lung is important when you're looking at what these pulmonary nodules might be. Because if you look at this, this is called the secondary pulmonary lobule. It's the smallest unit that you can see on HRCT. And each of these units contains about 3 to 5 acini. Sounds like a bad word. It's not. These acini actually are where gas exchange occurs. And then they have these septa that go around them. And within these septa, you can see that there's little veins and there's lymphatics that travel through there. And that's important to remember as we're going through our differential diagnosis for what's going on CT scans. Because if something's lighting up in that area on the CT scan, you know that it's something that has to do with potentially a vascular issue or a lymphatic issue. Also in the middle of these septa, you have these terminal bronchioles and these terminal bronchial arteries that sometimes, if they light up in a very systematic way, kind of central lobular distribution throughout the CT scan, you can tell that maybe there is something going on with one of those two things. So it's a really good idea to just kind of keep that in mind. And when you look at these CT scans, this is kind of an example. In this particular example, do we have a pointer by chance? In this particular example, let me see if I can use my mouse. There we go. That'll work. You can see that the septa are just kind of lit up here. And so this can, again, if you remember your anatomy, this can usually be one of two things. It can be something with regard to the lymphatics or something in regard to vascular congestion. So it's fairly limited. Remember that when you're looking at the anatomy, this is just another view here, but you have lymphatics that actually invaginate through the fissure. Here's the fissure, the separation between the lobes. You actually have lymphatics that run, that go through there. So when you're looking at that on a CT scan and you have this fissure that is right here and it lights up, you think, okay, well, is this volume in there? Is this lymphangitic spread from a malignancy? So something to think about as you're looking at these CT scans. As I mentioned, the differential is actually fairly limited with regards to some thickening of that of the lobule. It can be pulmonary edema, it can be lymphangitic spread, but sarcoid, which is another disease that affects the lymphatic system primarily, can also light up. So this is something we see often when we're looking at pulmonary nodules and trying to figure out what the differential of the nodules will be. Sarcoid, as you all may have noticed through clinic evaluations and things, people with sarcoid show up in our clinic often. And so, okay, here you have an 86-year-old with shortness of breath. So again, looking at our anatomy, you can see that those, you do have involvement of some of these intralobular septa. You see this thickening, but you see it in a large heart, and you see some small little pleural effusions there. So this is actually how pulmonary edema can look on a CT scan. But here you see another 86-year-old who has shortness of breath. This is similar to the CT I showed you earlier. And again, you see here the fissure is involved, the lymphatics invaginate through that fissure. You can see that there's more of a nodularity going on, and then you can see it's unilateral. So this is generally something that's more suggestive of lymphangitic spread. And it's generally more of kind of some nodularity. So Dr. Hilger went over some of this already, so I won't harp on this, but you can kind of see on CT, you see either kind of a ground glass nodule, mixed ground glass nodules, or solid nodules. When you have these ground glass nodules, these are the ones that are really tricky. The folks that deal with these on from an incidental basis, know that these are always tough because sometimes they just disappear. These are things that just can be, related to inflammation. They can be related to infection, people who are smokers. I mean, all kinds of things that can pop up on CTs that are ground glass. So they're tough. In fact, day before yesterday in clinic, we saw somebody that had a stable ground glass nodule for 5 years. And then year 6, the patient was still smoking. Year 6, this thing took off and quadrupled in size. And it's just like, it's really, really hard. And, you're following the guidelines, you follow them for 5 years, but sometimes these things just take off and it's really hard to, so these are the tricky ones. The mixed ground glass ones can be a little bit more dangerous and you follow that kind of solid component in there. And then we'll talk through solitary pulmonary nodules as well. But they can be solitary, solid pulmonary nodules. They can be perilymphatic, random in distribution, and central lobular. And this is just a little bit of a differential that I talked about. But honestly, they fall into one of really 3 big categories: infectious, inflammatory, or malignant. And there can be a lot of different things in each of those categories. But these can just be benign. And like Dr. Hilger had said, in this part of the country, we see a lot of histoplasmosis and calcified nodules. A lot of these can just be intrapulmonary lymph nodes, and we'll talk a little bit about that. As far as calcification patterns go, sometimes people see calcifications and they're like, oh, it's fine. These are calcified nodules. And most of the time they're right, because of the area we live in with histoplasmosis. If you see these types of benign patterns of calcification, that can certainly be something that is suggestive of prior, what they call granulomatous disease or histoplasmosis. But there can be some malignant patterns of calcification, and you can see this kind of eccentric pattern of calcification. So you shouldn't automatically disregard calcified pulmonary nodules. But if it's completely calcified through, it is a benign pattern, and we generally don't follow those at all. Remember to always look at the soft tissue windows, and what I mean by windows is kind of how how it's comparing to different structures inside the chest. And because if they come up as more related to fat, for example, you look at something that's called a Hounsfield unit, and if it's more suggestive of kind of fatty tissue, then again, when we're looking at pulmonary nodule and we're trying to evaluate for malignancy, we say it's probably not malignant because it has a Hounsfield unit of -30 to -40. These are something that the radiologist can comment on and look at in the report. And so this particular example is a hamartoma, something else that we see inside the lung when we're working up pulmonary nodules. But remember, it's important to put this together with the patient. You're looking at a patient in the clinic. She's 92 years old. She has a history of aspiration. 92-year-olds love to tell you about their bowels and what's happening with their bowels. And so they talk about drinking mineral oil. When you look at this, when, in the soft tissue windows, you can see that this, if you look at this kind of in the lung windows, you can see this maybe has a little irregularity to it. It can look concerning for a malignancy. Then you look at it in the soft tissue windows and it looks a little bit different. Again, Hounsfield units, -30, -40. This can be something like a lipoid pneumonia. People can aspirate when they're taking mineral oil, and then all this stuff shows up in the lungs. So these are things that we don't see real often, but we can certainly see that, and it's important to put it together with the patient presentation. Patients that can also, if you look at the mediastinal windows, can also have kind of these things that look like, you look at this and it looks like a malignancy. It's got kind of a ground glass halo here. But again, putting it together, patient just had a right heart cath. You can see pulmonary artery pseudoaneurysms, Swan-Ganz catheters, things like that. I've seen those get wedged into subsegmental pulmonary arteries, and things can, you can actually get some aneurysms from those. Here's another example of a patient with vascular disease, and what you can see here is that you can see these little vessels that are going back and forth to this nodule. You do not want to stick a needle in that. It's important to really make sure that you evaluate these before you take these patients to biopsy or do perhaps a contrast CT follow-up. To evaluate for things like AVMs, which are arteriovenous malformations. And ideally, you don't see it this beautifully, but sometimes you can see vascular structures going to and from the lesion. This is something that Dr. Hilger had talked about. This is actually what we see really most commonly in a lot of patients with pulmonary nodules that are just, sub 6 millimeter pulmonary nodules. And these actually end up just being intrapulmonary lymph nodes. Intrapulmonary lymph nodes, oftentimes they have kind of an elliptical structure to them. And again, remembering your anatomy, they kind of sit in these intralobular septa, and they have like little tails coming off of them oftentimes. And that can be actually just a little bit of a vessel that's coming off of that intrapulmonary lymph node in that septa area. So that's always, you can see here, kind of like a little tail that's coming off of this thing. So that's most commonly what you see depending on its location. And so keep that in your differential diagnosis. This is a good example of a ground glass nodule. As we were talking about in the last lecture, these ground glass nodules, again, can be very tricky. Sometimes they can be mixed. They are different than ground glass opacities, right? I mean, so this is where it gets a little tricky, especially with our AI software and our incidental program that we use. It is hard to differentiate between just kind of a ground glass opacification and a really well demarcated ground glass nodule. Ground glass nodules can be precursors to malignancy. They can be anywhere, anything from atypical adenomatous hyperplasia versus adenocarcinoma in situ. These are typically very slow growing. Look for not only an increase in size of this, but also an increase in density as it relates to growth with these ground glass nodules. Nodules can also be in this perilymphatic distribution. And as I mentioned, so like, for example, here is the fissure coming along right here. And you can see if there are nodules that are following this kind of fissure and around the bronchovascular bundles, you think that this is, from an anatomy standpoint, again, this is probably more related to a lymphatic process. And this is very classic for sarcoidosis. Where the differential is small, but keep in mind this can be lymphangitic spread, but sarcoid generally has these kind of coalescing pulmonary nodules that kind of coalesce again around these bronchovascular bundles right here, again along and through the fissure. And so we will get a lot of referrals for these types of pulmonary nodules where you look at it and you're like, this looks like sarcoid to me. And, oftentimes these patients still end up going for biopsy, and you can see findings on pathology that are pretty classic for sarcoid. They do favor, in sarcoid, they tend to favor upper lungs and spare the lower a little bit. They tend to coalesce. We call this the galaxy sign, kind of like a starry sky pattern where you see these little nodules that coalesce and form this kind of galaxy sign as seen on that CT before. As far as random nodules, the differential diagnosis for kind of randomly distributed pulmonary nodules on a CT scan, you're talking really about things like infectious etiologies and hematogenous spread of metastatic malignancy. And you can get things, infectious etiologies such as, don't forget about things like miliary TB. TB is making a comeback these days, so you definitely have to keep an eye out for things like that. But we see that less commonly, obviously. But you want to think about infectious etiologies and metastatic malignancy with kind of randomly distributed pulmonary nodules. As far as central lobular nodules go, this is what I was talking about on my first slide with the anatomy. If you see these nodules that are kind of occurring in the center of that secondary lobule and they're evenly spaced, generally, there are only a couple of things that can be. And again, remembering the anatomy, you've got that vessel in the middle of that lobule and you've got that terminal bronchiole in the middle of that lobule. And so when you have that, the differential diagnosis is generally something like hypersensitivity pneumonitis from, maybe perhaps an exposure or recurrent aspiration, or infectious etiologies, inflammatory bronchiolitis, or even with that vessel in there, sometimes it can be some type of vasculitis. This is what we mean by tree and bud findings. You can see this kind of tree and bud changes, and you can see why they call it a tree and bud. It definitely looks like that on CT scan. It is almost always indicative of some type of acute endobronchial or active endobronchial process because of the distribution of that. you could see it with mucus plugging, but again, infection, you can also get some organizing pneumonia. You will see that terminology often as well with kind of some inflammatory granulation tissue. Don't forget, again, about things when you see lung masses and people, Dr. Hilger had just shown us a slide up here with kind of, he called it, a pseudocavitation. Basically, the malignancy can be cavitary, right? So, but again, TB is something that I think we're seeing more and more commonly around the globe. And so it's something that we should keep an eye out for. Whenever you see a cavitary lesion, make sure we're checking AFBs and all of those things. Here you have, again, a 92 is the year to be to aspirate, I think. So you get chronic aspiration in a patient. And here's a really good example of what I was talking about with this kind of randomly distributed centralobular fuzzy nodules that are kind of well distributed all through the pulmonary parenchyma. This ends up being a hypersensitivity pneumonitis. And these are not things that we typically worry about with regards to a malignancy or metastatic disease or anything like that. I talked about this already. Don't confuse these kind of ground glass opacities with these ground glass nodules. And I'll kind of skip over this because I talked about most of this. The differential diagnosis is wide. It can be fluid, infection, blood, multiple different things. Don't forget, however, about the most common things that can be in the lungs with when you see lung masses. And that is just, a run-of-the-mill classic multifocal pneumonia. When you see these big masses and consolidations, you look for things like air bronchograms, where you can see the actual airway penetrating through the lesion. If you have a solid mass in there, you're not going to be able to see that airway. That airway is going to be crunched down and collapsed. And so if it's a pneumonia, you're going to be able to see, not always, but typically you're going to be able to see kind of this airway protrude through the actual lesion. So keep in mind, a lot of what we end up biopsying, sometimes this does look like a big lung mass, right? And is concerning for malignancy sometimes, but pneumonia is certainly always in the differential. You've got a patient here that has had some weight loss, and you see this kind of random distribution of pulmonary nodules associated with other parenchymal changes like bronchiectasis. You can see kind of a right middle lobe wedge-shaped bronchiectatic change right here. This is pretty classic for MAC, and we see a lot of MAC when because these can be PET positive too. We do a PET scan on these patients. They light up, and it can be an atypical mycobacterial infection. MAC stands for Mycobacterium avium complex, which is basically an atypical mycobacterial infection. And if you guys have ever heard of Lady Windermere syndrome, for those of you that follow Shakespeare, this is a very classic Lady Windermere syndrome where you have a frail 86-year-old who's losing a bunch of weight. You have a right middle lobe kind of wedge-like area right there. It's just a classic presentation for MAC. Let's talk a little bit about what we are really focusing on today with regards to pulmonary nodules, and that's malignancy. So Dr. Hilger already talked about this, but as of 2021, you all probably know that the United States Preventative Services Task Force revised its recommendations with screening. The recommendation was really based on evidence from multiple studies, the largest of which and most recent of which was the Nelson trial, which he talked about, showing more so younger patients. It was a more recent trial and really provided more evidence that this is something that is certainly beneficial to our patients. And most of the nodules that we still find today are actually incidentally found. That's just still where we are. We talked a little bit about our screening numbers nationally. They're going up, which is fantastic. But nationally and globally, most lung cancers are still found incidentally. So it is important to focus on incidental nodules. And this is a slide from Intuitive, but basically, shows that with the Nelson trial, for example, this is a good example of how these nodules tend to be, these findings are where they are distributed in the lungs. And oftentimes they are in places that are difficult to reach. And Dr. Wells is going to talk a little bit about some of the technology that we have that allows us to be able to reach those nodules in difficult to access areas in the superior segments and up in the apices of the lung and in the periphery. But there are a ton of nodules that are found in hospitals every day. Most of these go unaddressed, and so that's why you will have these discussions around, in different regions of the country with hospitals that are now starting up incidental program. We are ahead of the game, certainly with making sure that we have good programs to identify these incidental nodules. But, I was just in a meeting yesterday in Atlantic, Iowa about them, these critical access hospitals trying to form incidental programs where they are trying to capture these nodules for various reasons, obviously patient outcomes, but also because of medical legal reasons, right? I mean, someone comes into your ER and you capture a 1.2 centimeter pulmonary nodule, and they come back a year later with symptoms again, and you scan them and it's a metastatic malignancy. And the patient's like, hey, I was here a year ago, and what happened? And so these end up being an issue for a lot of folks around the country. So there's a lot of discussion, certainly around incidental programs. This is actually a CT scan from our system of just a vascular scan for a abdominal aortic or for a aortic aneurysm. And you can just see how these ground glass nodules over time tend to just change. They grow, they certainly thicken a little bit. And so something to keep an eye on. This is, again, important to just kind of be able to manage all of this data through an incidental program and kind of help track all this data. And so a lot of you in this room are very involved with being able to support that process and coordinate all of these things, because it takes a lot of labor and a lot of manpower to do this. So, but really, as far as it relates to malignancy, it's all about pretest probability. And pretest probability is what really makes it so that you can make a decision on what to do with all of these nodules. I think that's the point of this lecture, is that we have all these things that pop up in the lungs. And I went through a lot of those things, and we just don't know oftentimes what's malignancy and what's not. So you have to sit down, look through things with the patient, find out exactly what their particular risk factors are. The Mayo Clinic model is something that we like to use often to help risk stratify based on patients' age and their smoking status, whether they have extrathoracic malignancies, the size, radiologic characteristics, whether these lesions are spiculated. Smoke rises, right? Upper lobe cancers are more common. And so, distribution, all of those things are certainly important, but really size does weigh significantly with the chance of malignancy. If you have a 2 centimeter lesion, your pretest probability, regardless, is going to be significantly higher. So something to keep that in mind. So then we kind of stratify these patients, and we say, okay, you either fall into a very low pretest probability, a high pretest probability, or somewhere in the middle, which is really the majority of what we deal with when we're trying to figure out what's going on with these lesions. They all kind of fall into this big category of kind of intermediate pretest probability. You can see from a probability standpoint, 5 to 65%. It's sometimes very hard to figure out what to do with those. And so this is where conversations come in with the patients, and clinical judgment obviously comes in. It's pretty clear what to do if you have a very, very low risk lesion. And it's very clear what to do if you have a very, very high risk lesion, right? But when you're lumped in the middle of that, that's when you start having these discussions about what it is that's best to do. And there's so many factors that go into that. So one of the things we use in our clinic is kind of a reclassification biomarker that kind of helps reclassify the risk of malignancy. So for these patients that fall into this category, with a very kind of intermediate risk of, and we don't do this, on everybody who falls into that category, but if we're really looking for something else to help reclassify that risk from a statistical standpoint, we can do kind of these blood-based assays. There's one available, XL2 CDT testing, that can either help rule in or rule out malignancy, that we will sometimes use. As you all know, part of the battle with this all is, you get all of these nodules that come in. It's really focusing on this algorithm of how we get these patients through the care continuum. You can get them through incidental findings, you can get them through low dose CTs, but that sometimes these patients are just referred everywhere, right? They're referred to medical oncology. The oncologist looks at them, deer in the headlights, and they're like, what am I supposed to do? Because I don't know what's going on yet. You need to go see this person, and then you need a biopsy, we need tissue. And then, a month and a half later, they come back to us and we're talking to them about doing a biopsy. So it's really important to have a very clear pathway to be able to help kind of get our patients from identification to biopsy to treatment in a very linear fashion. And so really focusing on a comprehensive program like we have developed within our health system, certainly with capturing patients and improving diagnostics, optimizing treatment, focusing on accelerating recovery and being engaged. And Dr. Wells is going to talk about some of the things that we have done with as it relates to early diagnostics and robotic bronchoscopy. Yeah.
Have you seen any statistical significant increases with veterans of the Gulf War?
Yeah, I don't know statistically if they are significant, but we do know there are so many confounding variables when it relates to exposure history, because there's oftentimes people who are exposed to one thing are exposed to several things. And that makes it very, very difficult to rule out those confounding variables and say, okay, you were in the Gulf War, and so this, you have a higher likelihood of having a pulmonary nodule in the upper lobe. However, we know that obviously we know that exposure to things like burn pits and there's Camp Lejeune and all these things that are known with regards to exposure history, Agent Orange and all of these things, right? But specifically as it relates to nodules and being implemented in the algorithm for having a higher probability of malignancy, as we are evaluating these patients, oftentimes those are the things that we want to know. We want to know, what is your exposure history, and how does that then impact your risk for cancer? Good question. So vaping and radon was the question. And again, with radon, similar to the first question, where there are so many confounding variables, it is very difficult to tease out some of these, some of the impact with radon. But we certainly know that radon has a clear correlation with lung cancer, and it's important to have all the mitigation and everything else that we work on with radon. This region that we live in has higher radon levels. And so we do see, but also this region that we live in has higher smoking levels, and so higher prevalence of smoking. And so it is very difficult to tease some of those things out, but absolutely something that we should be going over with our patients in the office and discussing. We've all seen patients that have never smoked in their lives and have cancer. And so there are obviously other reasons besides radon and environmental exposures. There are genetic drivers, and people sometimes just get lung cancer, and it's a terrible thing, and it doesn't always have to be associated with smoking or some type of exposure. But yes, absolutely. Vaping. So there are some acetaldehyde and other chemical components inside vaping that are known carcinogens. We have not linked that to, as we have with cigarettes, clearly to say that that they cause lung cancer. There's a slew of litigation that I'm sure is going to be coming down the road with vaping, and it is a lot of the Philip Morris and a lot of the folks that are actually involved in some of this, so they're experts with all of that. What we see, as pulmonologists, is more vaping associated lung injury, and that can be, from a radiologic standpoint, more of a ground glass distribution, and more of a kind of a the distribution is quite different than kind of a focal pulmonary nodule. We get those questions often from patients who, they come with 1.5 centimeter pulmonary nodule. And, their family members like, well, they've been vaping for a couple of years, and it just doesn't look like that on a CT scan. But absolutely, we talk to our patients about how they should not be vaping, and there are carcinogens and all of those things. Good questions. Thank you, guys.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.